Now, how early can we start in this acute decompensated heart failure? Whether we should start it at follow-up, whether we should start during discharge. So the answer to this somewhat comes from the Pioneer Heart Failure trial. This was for patients with hospitalized with ADHF with ejection fraction of less than 40%. That's what we define as the HFrEF. While the patients were being stabilized, that means when the patients had a systolic blood pressure of more than 100 in the previous 6 hours, there was no symptomatic hypotension, there was no change in IV diuretics or no IV inotropes or vasodilators. These patients were then sort of randomized to enalapril and ARNI. And this was the in-hospital initiation, and various other parameters like tolerability, the levels of NT-proBNP, and of course the clinical outcomes was studied. Now, what you can see here, NT-proBNP is a very good surrogate marker of outcomes in heart failure. And so therefore, a reduction in NT-proBNP tells us the prognosis of the patient to a large extent. Now, if you look at the change in NT-proBNP, you find that the ARNI reduces the NT-proBNP much better. But more importantly, also you can see that this effect starts quite early. So if you look at the end of 1 week itself, there is a significant difference in the level of NT-proBNP. So there is a better NT-proBNP reduction, and that starts very early. Now, if you look at the cardiovascular mortality or HHF or hospitalization for heart failure, here again, you will find that there is a definite benefit. These curves separate from quite early period, and they keep on diverging. So therefore, there is a very continued benefit. Now, if you look at the pre-specified subgroup analysis, whether it is a de novo heart failure, so the blue bars are the ARNI, the red bars are the enalapril. So you will find that the change in NT-proBNP, all the blue bars are sort of more than the red bars. So in all these situations, that means whether it is a de novo, whether it is chronic HF which is worsened, whether the patient is having ACE inhibitor or ARB, or he is not having previous treatment with ACE inhibitor ARB. So in all these subset, the ARNI is able to reduce NT-proBNP in a more superior way. If you look at the outcomes in patients without prior ACE inhibitor ARB exposure, then you will find that again, the outcomes in terms of NT-proBNP are definitely far superior as compared to enalapril, and the cardiovascular death or hospitalization for heart failure also. And as I said earlier, that the benefit starts pretty early. So these are the number of days. So you can see that at 7 days itself, as we saw in some of the previous slides, that at 7 days itself, you are getting benefit. And how much is the reduction? It is almost like 50%. So there is, in those patients who are not previously exposed to ACE inhibitor ARB, you get a very robust reduction in the combined endpoint of cardiovascular mortality and HHF.